Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show.
Structure it based on its physicochemical properties, pharmacodynamics, pharmacokinetics, with a subsequent wander into the monitoring of neuromuscular blockade. We shouldn't be using drugs unless we know how they behave inside a person, so that we can appreciate their characteristics, behaviours and foibles in the context of our diverse patient population. So without further ado, we'll get on with the show. So, getting into the bulk of it, we're talking Vecuronium today, as you well know. Brand name, Norcuron, which does again sound like a dodgy Decepticon transformer, but there we have it. Vecuronium is classified as a monoquaternary aminosteroid of the aminosteroid neuromuscular blocking agents. And it is the monoquaternary analogue of pancuronium. Where's it from? Who found it? So it was synthesized by Savage and co-works at the Organon Research Laboratories in the US. It was found in the same series of agents that yielded pancuronium. Remember, it's like a stereoisomer in pancuronium. And whilst they knew it existed, they thought that it wasn't really a very useful stereoisomer in that gaggle of molecules in pancuronium because it didn't seem to be very potent. Ultimately, what transpired was they weren't storing it very well. It is unstable in aqueous solution, so if you leave your Vecuronium in a test tube and come back to it the following day, it's not going to be as potent as it undergoes hydrolysis. So, colour and appearance. So it is a lyophilized powder requiring reconstitution in water. When you do so, it is stable for 24 hours. And that's because it's not just in water. There's a few other things in that ampule. There's a citrate phosphate buffer. There's some mannitol to achieve a sensible tonicity, so it matches your plasma. And there is either sodium hydroxide or phosphoric acid to achieve a pH of around 4. It will, once made up, be a clear, colourless isotonic solution, classically mixed to 2 milligrams per mil. And it is stable for a day up to about 25 degrees C, once made up. Its molecular weight, 637 grams per mole. Remember that our benzyl lysoquinoliniums are quite big molecules, ish around twice the size or a third bigger, and Vecuronium is a heavier molecule than rocuronium. Now, if anyone wants to look at a lovely diagram of a molecule, check out the show notes. There is a public domain image of Vecuronium, looking frankly complicated and well beyond me. So, mechanisms of action, pharmacodynamics, side effects of Vecuronium. If you're talking about these drugs, you need to be able to tell the examiner how it works, the doses you use, and the side effect profile. And we're going to introduce an additional concept here. Now we're going back in time and we're thinking about slightly older drugs. We know that Vecuronium, rocuronium, and all its other neuromuscular blocking pals act on the nicotinic acetylcholine receptor. And you might have seen the abbreviation N2 knocking around. This N2, as you might be able to surmise, means that there's probably an N1 nicotinic acetylcholine receptor somewhere, and you would be right. The N1 is sometimes described as a ganglionic nicotinic receptor or vagal nicotinic receptors, and these are receptors for acetylcholine. Remember, it's called nicotinic just because nicotine binds to it, not because it's some other clever thing going on and they knew what nicotine was a bit before they knew what acetylcholine was. I don't think if you smoke too much you'd get floppy though, but who knows? That'll be an interesting question, but that's for another time. But ultimately, more modern drugs do not go forth and tickle N1 receptors. But once upon a time, they were less specific, and they did indeed tickle N1 receptors. Just to highlight here, Vecuronium is 80 times more potent at the neuromuscular junctions receptors than its capacities to modulate your parasympathetic vagal nerve side of things. Really old-fashioned drugs were a little bit less discriminate than that. And this is down to the nature of the molecule. But you should certainly be able to reel off in the exam that
Non-depolarizing neuromuscular blocking agents act by non-competitive antagonism of acetylcholine at the neuromuscular junction, acting on post-junctional receptors, the muscle, but also pre-junctional receptors, where modulation of the function of that nerve ending occurs. This is where fade comes from. Dosing of Vecuronium. So Vecuronium is 3 to 4 times as potent as Atracurium, and as you can remember, we give about 0.5 milligram per kilo-ish as a standard intubated dose, because otherwise you'd be waiting quite some time. And the standard intubated dose of Vecuronium is 0.1 milligrams per kilo. The ED95 is about 50 micrograms per kilo. It just takes a while to work. So if you gave someone 50 mics per kilo, eventually they would be intubatable. Onset time is 90 to 120 seconds, which is somewhat similar to Rocuronium, isn't it? You will achieve maximal blockade at 3 to 5 minutes, and offset is 25 to 40 minutes. And you would see 95% recovery of those twitches at 45 minutes. Generally, if you've intubated someone with Vecuronium and then the surgeon's saying, oh, they're too tight, you might be tempted to give some more, and it would be recommended to give about a quarter of the dose you used to intubate them. So if you're intubating a 75 kilo person, you might use 6 to 7.5 milligrams. So you might give them 1.5 milligrams or 2 milligrams-ish to keep them paralyzed. You can also infuse it, as you might expect. So remember, Vecuronium is more potent. We're giving 6 milligrams to intubate someone. With Rocuronium, you might end up giving 40. So now you know that I'm going to tell you, yet again, about Bowman's principle, whereby the potency of a drug is inversely proportional to its onset time, because you just can't give as much of it. This is why we use Rocuronium for our SIs, because we can use a big whacking dose, achieve a reasonable concentration gradient from plasma to neuromuscular junction, and therefore flood that neuromuscular junction with enough drug to achieve a rapid onset time. So continuing with pharmacodynamics, what the drug does to the body, you would want to have an organised approach to discussing side effects, and that would classically go down the route of cardiac, respiratory, central nervous system and other, but it naturally varies with how much mischief the drug causes. I hope you're coming to the conclusion that paralysing drugs other than suxamethonium are actually generally quite stable. The headlines to remember are really, does it mess around with histamine and its potential for anaphylaxis? That's a nasty side effect. So, Vecuronium, large doses can slightly nudge up your cardiac output and drop your systemic vascular resistance, and these are probably a compensatory thing going on here. Respiratory side effects doesn't really do anything with histamine, but naturally they are not going to breathe. Don't forget that, very important. I wouldn't say that in the exam though, because you'd look a bit daft to say, well, the paralysing drug is going to stop them breathing. It's probably inferred, but it depends on your rapport with the examiner. And interestingly, Vecuronium might reduce your prothrombin time. I don't think it's going to be a treatment for massive obstetric hemorrhage though. Interestingly, Segamodex, whilst everyone knows it works on Rocuronium, it also works on Vecuronium, and its effect will be potentiated by the physiological state of the patient, their electrolyte state, their temperature, etc., etc. Vecuronium pharmacokinetics. Remember kinetics, what the body does to the drug. Break it down into absorption, distribution, metabolism, elimination. How is Vecuronium absorbed? Well, you could probably drink it. It probably wouldn't do much. But distribution-wise, because remember we're giving it IV, it has a volume of distribution that is low, 0.18 to 0.27 in the grand scheme of things. Much like most other neuromuscular blocking drugs, they prefer watery places. It is 60 to 90% protein bound, and very small amounts can squeak across the placenta in a 9:1 ratio of Vecuronium measured in mum to Vecuronium measured in baby. Metabolism, Vecuronium. As with most other neuromuscular blocking drugs, the liver does get involved, and there are active metabolites of Vecuronium. It undergoes deacetylation. You don't really need to worry about the metabolic byproducts of Vecuronium. Now, if you're infusing Vecuronium over eons on intensive care in someone with liver failure, then you might see some accumulation. Does Segamodex work on those active metabolites? Who knows if Segamodex works on those active metabolites? Elimination, a quarter to a third comes out unchanged in the urine, so the liver just doesn't really get round to it. Those metabolites often come out in the bile. Clearance is 3 to 6.4 mils per kilo per minute, and your half-life is 30 to 80 minutes. Pretty brutal in an exam if someone is asking you what the clearance of Vecuronium is. That's more for, your appreciation and knowledge and reference if you want to compare clearances of drugs across the spectrum. They're more interested in you knowing the onset-offset times
and how to use the drug as opposed to quoting all the minutiae. So don't stress about that. Nice to know, not need to know. But I'm sure that they could ask you, what is a lyophilized powder? Because remember, thiopentone is one, remifentanil is one, and vecuronium is one, as well as quite a few of the antibiotics we use. So to be lyophilized or lyophilized is to freeze dry. So you have your molecule floating around in an aqueous solution. We know that the water's not good for it, so we want to get it out. So you freeze it and then dry it. And the ice is removed by sublimation. Sublimation meaning to transition from solid to gas without being a liquid. And this is achieved in a near vacuum. So if you drop the pressure, that water that's a bit frozen, that's quite cold, actually wouldn't mind being a gas. This is great for preserving drugs. It creates a stable powder that lasts, and you can reconstitute it at your leisure. Now, there's a link in the show notes to Agno Pharma, and they've got a really good webpage that describes it. And, they would offer to lyophilize your drugs if you so chose. I'm sure at great expense, but they describe the process quite well. Are lyophilized drugs useful? Well, yeah, if you're really in a really hot place and you're doing an anaesthetic in some compound in the Sahara Desert, do you want a drug that needs to be in a fridge? Absolutely not. You want a drug that you can leave in your rucksack and it work. You can imagine that your drug cupboard needs to be one that can tolerate heat in that environment and might work without too much electricity being an issue and your cold chain not being an issue. Anyhow, time for a brief mention about the sponsors of GasGasGas, Teach Me Anaesthetics. These guys are behind an excellent single best answer question resource. Firstly, I took the joyful, challenging and intermittent bashing through their 1100 plus questions which they have written for the FRCA primary exam. Now I secretly loved it, and there are plenty of questions to test your knowledge. When I was studying for the FRCA primary, it did not exist, but there were other packages online. These cost a lot more and they didn't really seem to reflect the content of the exams. Whilst doing them, I came across rehashed MRCP questions, which was not terribly inspiring and left me pretty cheesed off. Whereas these single best answer questions have been built from the ground up. They have not sniffed an MCQ in a past life. They are based on the anaesthetic science you need to know, and there are explainers with all the questions, so it builds your knowledge as you work through them. There is a multitude of ways you can study these questions. You could choose to do a random battle with 1100 plus questions, or split them into subject area. You can go back and redo the ones you've gotten wrong. It's very malleable. So if you've been thinking about which question resource you might want to get your hands on for the exam, you shouldn't really look any further than Teach Me Anaesthetics. If you reckon it's for you, all the links to Teach Me Anaesthetics from GasGasGas are affiliate links. So if you're signing up through one of those, you're helping to support GasGasGas. So if you think you're going to go for it, click a link with me. You know you want to. You'll not only be supporting your exam preparation, but you'll be supporting your 100% favourite Tell Your Nan Over Sunday Lunch podcast, which is of course GasGasGas. Okay, we are talking neuromuscular monitoring now. So it is naturally a cornerstone of safe anaesthetic care when neuromuscular blocking agents are used. Naturally, there are subjective and objective methods to monitoring your neuromuscular blockade. The subjective methods can be subdivided into clinical signs and the visual interpretation of muscle contraction amplitude when using a testing device, whereas objective methods of monitoring neuromuscular blockade involve a testing device that also has an integral sensing mechanism, i.e. it can measure the resultant movement or action potentials within the muscles associated with that nerve stimulus. When we talk about this nerve stimulus, it must be supramaximal. Enough of a zap to depolarize the whole motor nerve. You wouldn't want to partially depolarize it and therefore struggle to interpret the level of muscle contraction that you can achieve. So you have to really give it a whack. And this is generally greater than 60 milliamps, hence why you just crank up your Twitchy box to maximum. Normally that's 70, 80 or even 90 milliamps. Now, if you're curious, you can attach a Twitchy box to yourself, but certainly do not turn it up to max because it's actually very painful. We must realise that if you're waking someone up and they're half awake and maybe stirring and you check their twitches, that's a pain stimulus, quite a significant one. So you can attach it to yourself, turn it all the way down and press one of those buttons and you will twitch and it'll be quite funny. You can test it on medical students too if they're not completely terrified. Now, there is a bunch of buttons on that machine. And I remember when I first started, I just thought, oh, these acronyms, I don't know, but we do the TOF one. And TOF, train of 4. And that is 4 maximal amplitude stimuli, half a second apart, i.e. at 2 hertz. Remember, a hertz is an event every second. 1 hertz, 1 event per second. 2 hertz, 2 events per second. going to talk about TOF in more detail in a moment. There's a few other buttons. You have DBS. Now, this isn't the disclosure and barring service, but a double burst stimulus. This is a pair of signals 750 milliseconds apart. I'm sure you're seeing a bit of a trend. You need a number of signals, a distinct time separation apart in which to interpret naturally a change in these signals over time. And then there's PTC, and that is post-tetanic count. Yet another method for assessing depth of blockade, chiefly used for very deep blockade. How this works? It gives a 5-second burst of constant electrical stimulus. So you try and muster whatever sort of contraction you can out of that nerve. It then provides a stimulus every second until you stop. This gives you the capacity to assess very deep neuromuscular blockade because that tetanic contraction will liberate acetylcholine into the neuromuscular junction and increase your odds of achieving transmission to the muscle. The fancy nerve stimulator testing devices that are slowly creeping into NHS practice do train of fours, but also do post-tetanic counts to monitor when patients are significantly paralysed. Post-tetanic count helps to remind us that if you just do a train of 4 and don't see anything, and then do another train of 4 and see something and think, yes, they are reversible, well, you would find that no, they're not, because you have liberated acetylcholine that you otherwise would not have done, and otherwise the patient is unable to do, into their neuromuscular junction, so you can see that second train of 4 better. So, train of 4, why is it the default generally? It's commonly used. The consistent spacing of 4 contractions over time improves the operator's capacity to perceive fade across the first and the fourth stimuli. Why are we interested in fade? Surely we just say, oh, well, they're either paralysed or they're not paralysed. Well, we all know it's a spectrum. And we also should have at least a grip of the fact that the neuromuscular junction is abundantly set up to communicate a nerve signal to muscle, in that we have an excess of receptors and generally an excess of acetylcholine so we can reliably move. So a patient who has 4 twitches when you do a train of 4, but you see some fade, still has 70% in general of their nicotinic acetylcholine receptors occupied. 3 twitches, 80%, and no twitches, greater than 90% of all those receptors are blocked. So you're thinking, well, they've got 4 twitches, do we really need to reverse them? Side effects of neostigmine. The answer is, well, they've only got a third of the ability to achieve a muscle contraction. Are they going to tire quite easily? Is that a little bit marginal? Are they going to be weak? Are they going to aspirate? All bad news. Once upon a time, we would reverse at 3 twitches. Now we reverse at 4 twitches with fade. And ideally, once you have got them to a point where that 4th twitch is greater than 90% of the first twitch, you would classify them as reversed. Most folks just give everyone neostigmine and glycopyrrolate, and the zeitgeist, the culture, is progressively now towards just everyone gets Cigamedex with no thinking, just in case. I don't think I'm the just-in-case variety of doctor. You might well be. It's less thinking if you just routinely give it to everyone. Perhaps when we actually get consistent neuromuscular block monitoring, we will stop wasting Cigamedex unnecessarily. It does cause anaphylaxis. The institutional concern, as you might expect, is poorly reversed patients in recovery don't have a good time. They are jittery, jerky, and they are at increased risk of postoperative complications like postoperative pulmonary complications, PPCs, i.e. they get pneumonia. That's bad news following elective surgery. So, I mentioned subjective and objective methods. Subjective clinical signs, which, as you can probably imagine, are terribly unreliable. If they can consistently raise their head from the pillow, can they consistently keep their arm raised above their head? Are their tidal volumes greater than 500 mils? And can they sustain a strong hand grip? Those are all signs of recovery. And signs of non-recovery is if you've got a paralysed patient, obviously. If they have jerky, twitchy movements, they've got a hoarse voice or they've not got a voice. You find someone in respiratory distress in recovery. Either that's because they've inadvertently got some remifentanil that was left in the drip, a multitude of other reasons, or they're still paralysed. It's important to also note that some muscle units recover faster from blockade than other muscle units. The diaphragm's really quick, so they'll look like they're breathing. But the geniohyoid, these tiny little muscles in the neck, which can be considered a surrogate of airway tone, easy to measure geniohyoid, harder to get at the cricoarytenoids, isn't it? Demonstrates slower recovery. So someone could be breathing but actually still
not be able to swallow properly. And then objective methods. There are 4. Often they need to be calibrated pre-paralysis, so you get someone deep enough that they can't feel twitches and go into laryngospasm, obviously. Deliver those signals, measure the responses, and then paralyse the patient. And there are a bunch of methods. 4. EMG, electromyography. You measure the action potential in the muscle. AMG, acceleromyography. An accelerometer measures how much a thumb or a limb or an appendage swings. KMG, kinesiomyography. And there's a bend sensor between the thumb and the hand. So as you stimulate the ulnar nerve, you achieve contraction of adductor pollicis, makes the thumb move towards the palm. You measure that movement. And then mechanomyography, MMG, generally occurs in a research lab because you've got to really calibrate it. It's not very useful clinically. Where do people commonly stick the electrodes to test a nerve? The facial nerve is very convenient because you can generally get at the head unless it's ENT, head and neck, neurosurgery type stuff. Put it over the facial nerve and you'll either catch the temporal or the zygomatic, or if you lower the mandible, and it's quite easy to see those contractions because you can get close to the face. However, facial nerve recovers from block earlier than the diaphragm and earlier than the ulnar nerve. So whilst it's sensitive for the beginnings of recovery, it's not useful to identify the end point of recovery. The ulnar nerve triggers thumb abduction, as we know, but also all the intraossei of the hand. So if you stick it on your own, you'll feel your fingers want to draw together and contract to become apart at the same time-ish. And then there's posterior tibial or common perineal nerves. And this is handy if you can't get to the top end. You put these behind the medial malleolus or around the fibula head. I'm sure you've sometimes seen, wow, that's a great contraction, and other times, oh, that's not a very good contraction. This could be because the patient's at varying depths of paralysis, or it could be because you put the electrodes the wrong way around. So the black electrode, the dark electrode, is the negative one, and that should be distal. It delivers the energy. The red electrode should be closest to the heart, or more proximal. This will deliver energy more effectively to the nerve, and thus you'll see a better contraction. So why do we care? Why are we interested? Beyond the obvious humanitarian goal of not having aware, partially paralysed, hypoxic patients, we know that there is increased risk of post-operative pulmonary complications when there is an absence of full reversal, and therefore, certainly in an elective setting, in an otherwise well patient, if they were to get a post-op pneumonia, that's not great at all, quite suboptimal. It's going to impair recovery, and it might lead to prolonged hospitalisation. We know that once upon a time, recurarization was an issue. Long-acting drugs, pancuronium, etc. You'd antagonise them with some neostigmine, the patient would wake up, look great, you'd send them to recovery, and they'd get floppy again. Another risk that can lead to a paralysed patient in recovery or on the ward, which would certainly be bad, is an unflushed cannula with a agent that is potent in small doses, perhaps Vecuronium, because you can draw that up into quite any concentration you fancy. Potent paralytics in an unflushed cannula or line is bad news, because remember, we generally dose at multiples of the ED95. ED95 is the dose to achieve an effect in 95% of people for convenience of onset, classically. So a smidge of paralysing agent, given enough time to percolate around someone, will lead to a floppy patient. This is why we should be flushing our cannulas and getting those extensions off, because otherwise you might wake up at 2 in the morning and have to call the ward and say, whatever you do, don't use that cannula. Not something I've done, but something one of the consultants mentioned. Thankfully, it's in that sign out now, isn't it? Flush the cannula and you go, yes. It's now time for one of these delightful single best answer questions from Teach Me Anaesthesia. Now, naturally, I do love to keep you guys on your toes, and sometimes I ask you questions particular to the content of the podcast. Today's not that day. Today, we're talking scavenging. So, medical scavenging systems reduce environmental exposure to waste anaesthetic gases in theatre. What is the correct order of components in a scavenging system? These components are a receiving system, a transfer system, a collecting system, and a disposal system. You can probably work this one out. Or maybe not, because actually the answer starts with collecting system, transfer system, receiving system, disposal system. Now
There are 4 key components to a scavenging system, listed in order of gas flow from patient to the environment, i.e. out the window. You have a collecting system, and this is 30 millimeters in diameter. That typically plumbs into the APL valve. It's 30 millimeters, so you can't accidentally connect it into your circuit. Remember, circuits are 18-22 millimeter adapters. There's a transfer system. This is corrugated plastic hose connecting the collecting system to the receiving system. Now, this receiving system can either be open or closed. Open systems are used with active scavenging only, while closed systems can be used with either active or passive. Remember, active or passive is there suction, or are you just hoping that it's going to float down a pipe and out the window? A closed receiving system contains positive and negative pressure release valves because you don't want to inadvertently deliver pressure to your circuit because there's a high wind outside hooting down the valve. Pipe, hooting down the pipe. And then a disposal system, which eliminates these waste gases to the environment. That can be active, as we've said, vacuum-driven in high or low pressure systems, or passive, i.e. the exhalation of the patient empties gas out of your circuit into your collecting system, where it journeys along the transfer system into the receiving system, where it is subsequently disposed of. How super exciting. Aren't we all lucky to have to study this? There's an excellent book for equipment in anaesthesia called Equipment in Anaesthesia and Critical Care, a complete guide for the FRCA by Daniel Aston, Angus Rivers and Asalia Dharmadasa, which covers most things you need to know for equipment. We will get there eventually, but Teach Me Anaesthetics will get you there now. Check it out. In summary, Vecuronium is useful in environments where there are issues with cold chain management. It is reliably reversible with Sugamidex. It is notably more potent than Rocuronium. And remember that it is one of the isomers found in pancuronium. Having robust knowledge of onset and offset time of neuromuscular blocking agents is half the battle. The other half is appropriate and effective monitoring of the activity of these neuromuscular blocking agents in your particular patient, noting that everyone's different and the clearance of Vecuronium and Rocuronium is not independent of liver function. You can either observe with clinical signs, observe subjectively with train of 4 monitoring, or with proprietary modern neuromuscular blockade monitoring devices like electromyography, mechanicomyography, and kinesiomyography that we spoke about earlier. Anywho, I hope you certainly enjoyed that episode. I apologise if you hear the odd squeak of a child. I'll try and remove him in post-production as best as I can. Have a lovely week. Cheerio, and goodbye.
Ahoy, Team Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link, to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out gasgasgas.uk for the show notes, the diagrams, the details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day, don't overcook yourself, don't freak out, and keep studying.